facing the South Bronx.
Used needles and cracked vials are facts of daily life for youngsters who use the Bryant Avenue Bridge to get across the Bruckner Expressway.
The Centers for Disease Control estimates more than 100,000 people in New York City are infected with HIV.
That was the combined crack epidemic and AIDS epidemic. You know, they didn't know anything. Everybody was getting it.
But Norwood witnessed a motivation to help within the most vulnerable communities.
At that time, women who'd been diagnosed with AIDS had on average a year to live. And when we put out word and said, do you want to be a peer educator? Many women said they did. They said they wanted to spend whatever time they had left helping other people.
The community group, Health People, created more successful peer-led programs to focus on issues like asthma and smoking addiction.
And then diabetes just exploded. It became the most overwhelming thing, and at the same time, it's still the most unaddressed.
That same strategy, she realized, could be applied to this new crisis.
Peers are from your community. They'll have diabetes or pre-diabetes, but they'll also live in public housing in your community, and you can feel comfortable with them.
And with Health People's model, those peer counseling programs could be deployed quickly.
We have a 4-week training. That's 4 days a week for 4 weeks. It just works so well.
But today, diabetes is a growing crisis that Norwood says calls for more hands on deck.
Even though I do this every day, it's very hard still for me to get a handle on the level of mass illness we have. The only way is that we have to massively train local groups, and I mean massive, like an army.
Why aren't there 20 organizations like yours, just in New York City, never mind all around the country?
Because I think a part of it is that getting the funding for this is so rough. The city has a $1.6 billion public health budget. That's more than most countries in the state. I can't even count how many billions they have now with the federal aid. Neither one of them has a diabetes plan.
Despite the program's success, Norwood spends much of her time figuring out how to keep the lights on. Most of their operating budget is pieced together from foundation grants or from one-time government funds earmarked for other purposes, such as reducing emergency room visits. The leadership that could redirect more resources toward programs like yours, when they see what you've done, what do they say?
They sort of say, that's nice.
Norwood insists it's a costly oversight. Programs like hers have been proven to save not only lives, but also tax dollars.
The average cost for dialysis now is $90,000 a year per person.
A recent study calculates the average cost of a lower limb amputation at more than $50,000. The diabetes self-management program costs less than $1,000 per patient.
It is a missed opportunity and a bad financial decision to not provide the peer educational support.
We are in a different position now than we were in.
Congressman Raul Ruiz has fought the diabetes crisis on multiple fronts, first as an emergency room physician, and now as a lawmaker representing Southern California.
The prevention and the management and the peer education community health worker model is an incredible cost savings.
Especially for Medicare and Medicaid programs, which cover more than half the cost of diabetes care in the U.S.
We need to take a systemic, comprehensive approach to diabetes prevention and management.
Tackling the crisis has been a focus for Ruiz, who serves as vice chair of the Diabetes Caucus. One piece of legislation he's been working on would allow Medicare to cover self-management training in community-based settings and eliminate the copay for Medicare patients. If the bill passes, it would be a substantial step towards making programs like this more widely available. Ultimately, though, Norwood believes bigger changes are needed to correct the current system, where there's often more incentive to treat issues than to prevent them.
People have been turned into commodities for a sickness industry. And we have to look at that squarely.
Large-scale change, Ruiz says, will require the government to readjust how it looks at our healthcare system.
The economists in the Congressional Budget Office and others only factor in the immediate costs and their projections over the next 5, maybe 10 years, but they do not put into the cost savings for the prevention of an amputation into those equations.
Good morning, good morning. Welcome to the last day of the meeting, and I think the most exciting, however sobering topic, which is discussing PAD and disparities.
Policy change is what interventional cardiologist Dr. Felucio Faccarede is fighting for, too.
This is actually where the hard work begins.
Monday through Friday, Faccarede spends his days trying to prevent his patients from losing their limbs to peripheral artery disease. On weekends, he shares their stories with anyone who will listen.
We talk about raising awareness from a patient, provider, and community level, but policy and educating our lawmakers is actually at the forefront.
And he's made allies in Congress.
You know, I'm just so proud of our partnership and the things that he's doing.
For Congressman Donald Payne Jr., the diabetes crisis is personal.
I wanted my colleagues on the other side to see what an insulin patient looks like. You're looking at him. I need insulin in order to stay alive.
Payne has been fighting his own battle with diabetes for 30 years. He's now on dialysis and lives with many other complications, including heart disease and loss of feeling in his feet. It inspired him to create the PAD Caucus in 2019 to raise awareness among his colleagues.
They see their constituents that have lost limbs and, trying to understand why. And so we're bringing that knowledge to Congress.
Working with Faccarede, he has introduced legislation that would provide Medicare reimbursement for PAD screenings of at-risk patients with the goal of reducing amputations.
That is what we need to do across the board, not leave the burden to the patients.
That burden, he says, is not distributed equally.
We've seen that in spite of all the advancements in medicines, in technology, in advancements in care that we've seen in the healthcare field, the mortality rates for Black Americans has widened.
Faccarede says the problem starts with how clinical research is conducted.
If you look at guidelines and policies, they're based on data. Historically, less than 5% of African Americans have been included in research trials.
It's an issue that Ruiz is working to address through legislation.
Increasing the diversity in clinical trials so that we know that we're targeting communities that are hardest hit by diabetes, Hispanics, African Americans, Native Americans, and other minorities.
But for now, Faccarede believes the crisis is evident and the time to act is now.
I've seen enough data. I've seen enough coffins. I've seen enough memorials. I've seen enough amputees. I've seen enough dialysis machines. If you do not address their structural racism that led to their poor social determinants, then the perpetual cycle continues.
The doctor hopes that his advocacy will inspire others to work toward a solution.
I think we need more disruptive, positive ideas to move that needle. We need more change makers across the spectrum.